Today I'm going to give you an overview on diuretics to help prepare you for how these particular drugs impact on renal function and sodium and potassium handling. So all diuretics are really misnamed. They're all natriuretics. And so they all impact, they inhibit sodium reabsorption in the nephron. All of them. That's their mechanism of action. Some of them will work from within the tubular lumen. Some of them will work from the basolateral surface. All diuretics will increase urine flow rate. And this is represented by V dot, which is basically a volume per unit time. And finally, all diuretics will actually increase osmolar excretion rate. And that's often represented as UOSM V. So all diuretics will inhibit sodium reabsorption along the nephron at some particular point, and we'll talk shortly about which diuretics impact on which transporters in which segments. All diuretics will increase urine flow rate, and that's why a lot of times patients will refer to them as water pills because they make the patients have to go to the bathroom. And finally, all diuretics will increase osmolar excretion rate, so increase the amount of total osmoles the body has to get rid of over time. All right, so let's move to our nephron and the different sites of action for the major classes of diuretics. Remember, we have the proximal tubule, which comes right after the glomerulus, the thin descending limb of Henle, the thin ascending limb of Henle, the thick ascending limb of Henle, distal tubule, and collecting duct. And remember that from about the midpoint of the bend in the thin descending loop of Henle up through the end of the distal tubule, this segment is water impermeable. So no water moves, only solute. Okay? All right. So each segment has its own particular diuretic that has impact on sodium reabsorption in that particular area of the nephron. If we look at the proximal tubule, you'll remember, is responsible for bulk transport of sodium and water, responsible for up to 2/3 of the filtered load of sodium and water in an isoosmotic fashion, meaning that not only do you reabsorb sodium, but you also reabsorb water down its osmotic gradient through leaky, tight junctions between the epithelial cells. The diuretics that have the greatest impact in the proximal tubule are osmotic diuretics, and the most common peripherally administered osmotic diuretic is mannitol. However, any type of osmotic particle that's not reabsorbed in the proximal tubule has the potential to impact on sodium and water reabsorption in the proximal tubule. A perfect example is when glucose is at a high enough concentration that it's not all reabsorbed along the proximal tubule. That extra molecule and solute of glucose will cause an osmotic gradient to be established within the lumen and impede sodium and water reabsorption. So when diabetics are poorly controlled, their glucose levels and their filtered load of glucose goes up, and they get an osmotic diuresis. That osmotic diuresis also impacts on water reabsorption at the level of the thin descending limb. So we didn't really talk about sodium reabsorption in the thin descending limb. Remember, normally here, there's water that's being reabsorbed. So if I have osmotic diuretics that are impacting on sodium reabsorption in the proximal tubule, they will impact on water reabsorption in the thin descending limb. And I'll come back to osmotic diuretics in a second as we work our way through the nephron. The second major proximal tubular diuretic are carbonic anhydrase inhibitors, and the prototype of carbonic anhydrase inhibitors is acetazolamide. That blocks conversion of CO2 and water to bicarbonate and protons. It's chock full of the brush border in the proximal tubule, and it's very important for reabsorption of bicarbonate in the proximal tubule. Since sodium is tied to proton transport and bicarbonate reabsorption in the proximal tubule, if I block reabsorption of bicarbonate, I will block reabsorption of sodium, and carbonic anhydrase inhibitors will have an impact on both sodium excretion and bicarbonate excretion. So in the proximal tubule, we have osmotic diuretics and carbonic anhydrase inhibitors as being the major diuretics that impact in that segment. Since there's not a lot of active transport going on in the thin descending and thin ascending limb of Henle, there's no diuretics per se that work on those segments except for the osmotic diuretics in the thin descending limb. However, when we get to the loop, the thick ascending limb, this is where loop diuretics have their biggest impact. And loop diuretics block that triple transport sodium, potassium, 2-chloride symporter in the apical membrane and leave more solute in the lumen so that less sodium is being reabsorbed in the loop and makes its way to more distal segments of the nephron. The next phase of the nephron is the distal tubule, and the distal tubule diuretics include thiazides. Thiazide diuretics block the sodium chloride symporter in the apical membrane of the distal tubular cell and again impact on solute excretion by leaving more sodium and chloride behind in the lumen. Both loop diuretics and distal tubular diuretics will have an impact on the ability of the kidney to both concentrate and dilute the urine. And the distal tubule diuretics like thiazide will have an impact on the ability for the kidney to dilute the urine fully. Finally, that brings us to the collecting duct. And the collecting duct, the class of medications and diuretics that impact on sodium reabsorption, are called K-sparing. K-sparing diuretics because they have an impact on sodium reabsorption, which in turn has an impact on potassium secretion at the level of the principal cell. These diuretics, K-sparing diuretics, can be of the aldosterone antagonist type or they can be a sodium channel blocker type. So they can either work at the level of the lumen and block the sodium channel, the ENaC channel, or they can block the actions of aldosterone on the principal cell altogether. The net result is that there will be an increase in sodium excretion in the urine. Sodium and chloride, actually. So next, let's talk about the major side effect of almost all diuretics, which come down to fluid and electrolyte abnormalities. And the most common side effect of 95% of the diuretics is hypokalemia. Hypokalemia is low plasma potassium concentration. Now, diuretics can also impact on calcium and magnesium as well as acid-base status, but by far and away the most common side effect that we'll see is abnormalities in plasma potassium concentration. Now, all of those diuretics that have an impact on the nephron proximal to the collecting duct will all have a side effect of hypokalemia, potential side effect of hypokalemia. And I'd like to go through the mechanism with you. So in order to look for the mechanism and the physiology behind that, we're going to have to turn to the principal cell. And the principal cell, you'll remember, is in the collecting duct. It is interspersed between intercalated cells, which are responsible for acid-base transport. But the principal cell, you'll remember, is responsible for sodium reabsorption, potassium secretion, and water movement when ADH is present. And you'll remember that structurally, the principal cell has an apical sodium channel. It has, of course, the basolateral sodium-potassium ATPase with its associated pump leak. And it also has a luminal potassium channel. Ultrastructurally, the cell also has a central cilium, which acts as a mechanoreceptor. And we'll talk about that in a second. So just to take you through the process by which sodium is reabsorbed in the principal cell, you'll remember that sodium moves down its electrochemical gradient into the cell passively through the sodium channel in the apical membrane. As sodium moves down that electrochemical gradient, it leaves behind chloride and develops, the lumen of the nephron develops a negative net charge. So we establish a transepithelial potential that is lumen negative, and that lumen negative potential is what's responsible for driving chloride in a paracellular fashion. That lumen negative potential also has a positive impact on enhancing potassium secretion down its chemical gradient out of the cell. So the more lumen negative, the more potassium will be secreted as well. Now, let's talk about how this is impacted from the standpoint of diuretics. When I give a diuretic that is more proximal acting than the collecting duct, I will enhance and increase the sodium delivery to the distal nephron. And in doing that, I will also increase the flow or the volume of fluid coming through. The flow will have an impact on the cilium and will actually bend the cilium regardless of the solute concentration. The mechanoreceptor in the cilium will result in an increase in open time for that sodium channel and therefore enhance sodium reabsorption through that mechanism. If I've increased the amount of sodium that I've delivered to this particular segment through that increase in flow, I will have an impact and increase sodium reabsorption by both delivering more sodium and increasing the flow at the level of that sodium channel. The more sodium and the more flow, the more reabsorbed, the greater my lumen negative potential and therefore the greater my chloride driving force for reabsorption, but also the greater the driving force for potassium secretion. And so the more flow, the more sodium that I present to the principal cell, the more potassium I will secrete. That's going to be the case with any diuretic acting proximal to the to the collecting duct. So osmotic diuretics, acetazolamide, carbonic anhydrase inhibitors, loop diuretics, and distal tubular diuretics like thiazides. Finally, remember that this cell is also impacted by aldosterone. So aldosterone, which is a steroid hormone, as you know, and binds to intracellular receptors, will have a positive impact on the sodium-potassium ATPase activity and the number of sodium-potassium ATPases. Aldosterone will also have a positive effect on the number of sodium channels and the relative open time of the sodium channels. And eventually, aldosterone will have a positive impact on the number of potassium channels and their open time. So aldosterone will stimulate this cell to reabsorb sodium and secrete potassium as well, independently of flow. The diuretics that are going to impact on this at the level of the collecting duct are known as the K-sparing diuretics. They're the only diuretics that will not cause hypokalemia. And those diuretics will impact on either the aldosterone receptor, so they'll block the aldosterone receptor on the inside of the cell, or they'll have an impact on blocking the sodium channel on the luminal side of the cell. So they'll work by both mechanisms to impact on sodium reabsorption and therefore potassium secretion. A small caveat that you should always keep in mind is also that anytime you see an abnormality in serum or plasma potassium concentrations, 95% of the time, this is the cell model that's going to be responsible for that abnormality in the plasma. So you should automatically begin to think about what's going on at the level of the collecting duct if you see an abnormal potassium. Is there too much or too little aldosterone? Is there some aspect of this reabsorptive process that's being impacted and the potassium secretion that's being enhanced? Okay. So now that we know in general the basic principles of diuretics and how they impact on the nephron, both from the standpoint of sodium reabsorption and sodium excretion rate, as well as potassium excretion rate, let's take a look at how diuretics impact on ECF volume. And we'll talk briefly as well about the concept of steady state balance. So I've put a graph here with ECF volume, which will correspond to our sodium balance, and time. And ECF volume clinically can be evaluated from day to day based on weight. And we'll look at total body weight and changes in total body weight. And over the short term, any changes in body weight can be assumed to be secondary to changes in volume. And so changes in volume is typically related to changes in ECF volume, and that translates to sodium balance. So ECF volume, or I'll put in parentheses here, weight, is fairly stable, and we're kept in balance. Balance meaning especially the idea that input is equal to output. So what happens when we're out of balance? When we add a diuretic, we go out of balance. We have more leaving the body in the urine than we do when we're putting sodium in. So initially, the body begins to lose weight and the ECF volume decreases. With a decrease in ECF volume, there is less volume in the plasma and less volume in the vascular space, and that often correlates to people that are salt sensitive to a decrease in blood pressure. So diuretics, certain diuretics, can be used for blood pressure control, and that's one of the mechanisms by which that can occur. But why doesn't the diuretic continue to cause a decrease in ECF volume? Why doesn't the body continue to lose sodium in the urine as opposed to what's being put into it? The body is able to come into a new steady state balance, albeit at a lower level. The mechanism for that is predominantly what you've learned about from the standpoint of response to a decrease in ECV, where initially, as we go into a negative sodium balance, meaning we're losing more than we're putting in, that activates systems that are important in conserving sodium, especially the renin-angiotensin-aldosterone system. And that brings us back into a new steady state balance instead of continued decline. And over the long term, the majority of this steady state balance is because of the presence of aldosterone. And at this point in time, that level of aldosterone is higher than it was prior to the diuretic use. That mechanism for aldosterone is going to be represented back in the principal cell, and so that steady state is maintained at the distal nephron. You'll remember back on one of my earlier videos, we talked about the proximal nephron being important for bulk transport, and the distal nephron being important for fine-tuning and maintaining balance. Well, that's exactly what's occurring when we add the diuretic, put the patient initially into a negative sodium balance, and then with the addition of aldosterone levels that are higher, it allows us to enhance sodium reabsorption in the distal nephron, as well as part of the proximal segments because of some changes in hemodynamics. And we come back to a normal sodium steady state balance, yet albeit at a lower level over time.